Am I audible?
Yes.
Yeah. Good evening, everyone. On behalf of Iacm, I extend a warm welcome to all of you. Today is a special day for Iacm as we start our national online CME series. We plan to have it regularly on the first Thursday of every month. A famous Japanese proverb says, better than 100 days of diligent study is one day with a great teacher, and that is what these CMEs plan to do. We are delighted and honored to have luminaries like Professor Dr. M.M. Singh, Founder, Secretary IACM, Dr. K.K. Parikh sir, current President IACM, Dr. Grish Mathur sir, President of API, as our guests of honor. Now I will request Professor Dr. M.M. Singh to bless us with his words of wisdom.
Today, it is indeed a great nostalgic moment for me as it takes me 31 years back to the year 1992 when Indian Association of Clinical Medicine was formed, and I had the opportunity to be associated with it since its inception as founder secretary, as secretary constitution committee to frame the constitution of the association. I have seen its birth, early teething problems, its adolescence, and now it has entered its youth. Association is entering in fourth decade today when we are witnessing a new feather being added in the cap in the form of a first national online CME. It is a great moment for me to be more than happy today. And I am also sure Professor M.C. Gupta, founder president, will be happy in heaven and blessing us on this day today. All this has been possible due to the great vision and effort of our dynamic president, Professor K.K. Parikh. Dr. Parikh has been associated with this association and with me since its early days of the formation of the association. I may inform the audience that fourth conference of IACM was organized by Dr. K.K. Parikh as back in 1997 at Kota. And there were many firsts in that association, like first clinical medicine update was released in 1997 by Dr. N.L. Patni and Dr. K.K. Parikh as a organizing secretary. First monogram on fascicular block was published. First workshop on ECG was organized during that conference by me under the organizing secretaryship of Dr. K.K. Parikh. It is indeed heartening to see Indian Association of Clinical Medicine progress by leaps and bounds. The membership strength has increased to more than 2,000 as of today. Large number of city and state chapters, and now the zonal chapters are very active and doing exemplary work. President Dr. K.K. Parikh and his team deserves appreciation and congratulations. All the best for this new venture of IACM, online series of scientific presentation. Long live ICM.
Thank you, sir, for your encouraging words. I will now request President of IACM, Dr. K.K. Parikh sir, to bless us with his address.
Thank you, Dr. M.P. Singh. Good evening, friends, ladies and gentlemen, respected Dr. Professor M.M. Singh, founder secretary of IACM, Dr. Grish Mathur, president of API and guest of honor today, Dr. Subhash Chandra Gupta, past president IACM, Dr. H.S. Pathak, president elect IACM, our galaxy of speakers, Dr. Uma Kumar, professor and HOD, All India Institute of Medical Science, Rheumatology, Dr. Tarun Satija, senior consultant and professor of medicine, Dr. Aradhana, head of the Department of Rheumatology, SMS Medical College, Jaipur, our editor general, Dr. Chawla, friends, delegates attending this national CME program of IACM, it is my pleasure and a great honor to welcome all of you to this first National CME program of Iacm, which is being held today. Thank you very much, Dr. M. Singh, for reminding the past of Iacm, and we have got a very good past also for Iacm, and I hope that we will go to achieve great heights of Iacm in the future also under your blessings. Friends, to disseminate the knowledge to everyone and to even at the last corner of the country, Iacm governing body has decided, as Dr. MP Singh said, that it will be done every month to educate, to update our physicians and medical fraternity with the latest development in the medicine on different subjects. Today we have got luminaries, Dr. Uma Kumar, Dr. Aradhna, and Dr. Tarun Satija will be speaking on different subjects of polyarthritis. I think this is a very common subject, and the physicians are more involved in seeing patients of rheumatology. First they come to the physician and then they go to the rheumatologist when they are being referred to the senior rheumatologist. So I think this is a very common subject, and I hope, and we have got a very masters of their subjects, Dr. All the three speakers which are there today. So I think we have a great time today, and I hope that it will be much great useful to our delegates who are attending this CME program today. I would also like to thank our governing body member and a young neurophysician, Dr. MP Singh, whose effort has brought today's CME program, and he is a very hardworking person, and I hope under his efforts we will be able to do everything in organizing CME programs of Iacm. Thank you very much, everybody, and I hope we'll have a good time. Thank you. Jai Hind and Jai Iacm.
Thank you, sir, for your inspirational work. It's an honor to work in your team. I will now request President API, Dr. Girish Mathur, sir, President of the largest association of physicians in India, to say a few words and bless our association.
Thank you, Dr. Singh. A very good evening to all. Honorable Dr. K.K. Parikh, President Iacm, Professor M.M. Singh, past President Iacm and Founder Secretary, Dr. Subhash Gupta, past President Iacm, Dr. H.S. Pathak, President-elect, Dr. Suresh Kushwaha, Secretary Iacm, Dr. Chawla, Editor Iacm, and all the esteemed speaker of this evening, Professor Uma Kumar, Dr. Aradhna Singh, Dr. Satija, and friends. It's my immense pleasure to be a part of this wonderful program. I congratulate and compliment Dr. K.K. Parikh, President Iacm, to take this initiative to start this online series. These online CME series are his brainchild, and I salute his vision, energy, and enthusiasm, which are simply unmatched. And I also compliment him for choosing polyarthritis as a subject of this evening's discussion, which is of much clinical relevance to all practicing physicians. We have got an excellent panel of speakers this evening, Professor Uma Kumar, Dr. Aradhna Singh, Dr. Satija, and I'm looking forward for an exciting and meaningful discussion this evening. Thank you again for inviting me to this program. Thank you so much.
Thank you, sir. We are indeed honored to have you with us today. Moving on, the chairpersons for today's CME are Dr. S.C. Gupta, sir, past President Iacm, and Dr. H.S. Pathak, sir, President-elect Iacm, both clinicians par excellence. Today's CME will be moderated by Dr. M.P.S. Chawla, sir, editor of a journal, JIACM, another stalwart in clinical medicine. I will now request Dr. S.C. Gupta, sir, to begin the proceedings and introduce the first speaker, Dr. Tarun Satija, sir. Dr. S.C. Gupta, sir, to start the proceedings.
Yes, sir. Yes, sir. It's my great pleasure to be chairperson in such a common topic, polyarthritis, and every physician come across this problem again and again, and very, very happy I am. First of all, I would like to uh, introduce Dr. Dr. Tagun Satija. First of all, I came across Dr. Tagun Satija when I was editing the yearbook of Iacm in 2019 to send an article on non-resolving pneumonias. And that was a very good article which impressed me to my core. And he is governing body member Iacm, honorary treasurer and trustee to Dr. Lobo Memorial Trust, honorary treasurer Ludhiana chapter API, executive member Punjab chapter IACM, former executive member IM Ludhiana, awardee of prestigious Rotary exchange program for Italy and Sicily. Areas of interest is lifestyle management and health education for masses. Can I request Dr. Satija to begin the proceedings, please?
Thank you, sir. Am I audible? Okay. Thank you,
Yes.
sir, for a wonderful introduction. I, first of all, like to thank Dr. K.K. Parekh and Dr. M.P. Singh for giving me this opportunity to present my talk in front of this August gathering. Just a minute here. There's something wrong with my... Okay. So my topic is clinical approach to a patient with joint pain, especially polyarthritis. Well, we all know joint pain is a cardinal symptom in rheumatology, and a good evaluation requires very good history taking, physical examination, and a judicious use of investigations. Before we start evaluating a patient with joint pain, the first thing one should do is to see whether the patient is having the pain is arising from the articular surface or it is arising from the non-articular surface of the bone. I have on my slide, these are the structures which can cause joint pain: bursa, tendon, muscles, bones, ligaments. And one should also remember there are non-rheumatic conditions like depression, neuropathic pain, and hypothyroidism, which can cause pain, which may be perceived by patient to be arising from the articular pain, articular structure. We all know joint pain is usually diffuse and deep-seated, and it increases with inactive and passive movement, and it may be associated with joint swelling. Whereas pain which arises from non-articular surface like bursa, tendon, muscle, and bones is not usually associated with a joint swelling, and it increases more with active movement rather than passive movements. So this gives us a basic differentiate. This is the basic differentiating feature. Plus, in case of bursa involvement, you might have a localized point tenderness away from the joint line. Similarly, if tendon is involved, you have a tender elongated swelling. You might have a rub, which may be palpable or may be audible. And remember, when you stretch the tendon, the pain increases. Similarly, muscle pain is away from the joint line and is more diffuse, and there may be muscle tenderness. At this point, one must remember non-rheumatic conditions like depression and neuropathic pain may be perceived as arising from the joint by the patient, so one should rule it out. So in case of depression, you would have typical features of anxiety and depression, whereas in neuropathic pain, one would have continuous pain unrelated to movement of the joint and would be associated with numbness and paresthesias. Once you have definitely made sure it is arising from the joint surface, next thing is to see whether it is inflammatory or non-inflammatory in origin. Now, the characteristics of inflammatory arthritis are joint swelling, erythema, morning stiffness for more than 1 hour, symmetric pain, and remember, it occurs after rest. And common examples are rheumatoid arthritis, SLE, and spondyloarthropathy. At this point, I must say it is very important to differentiate between inflammatory arthritis and non-inflammatory arthritis, because if SLE or rheumatoid arthritis is missed, we can cause tremendous damage to the patient. Now, morning stiffness, as we all know, is what patient complains that he gets up in the morning and he finds it difficult to move. But as the time passes, he feels better. Now, if you have morning stiffness more than 1 hour, it is virtually suggestive of an inflammatory arthritis. Now, characteristics of non-inflammatory arthritis are patient may have joint swelling and tenderness, but there is no warmth and tenderness. And remember, there is no morning stiffness and pain is relieved by rest. And typical example is osteoarthritis knees. At this point, one can also feel the joints, and if you have any bony outgrowth there or a crepitus, it also goes in favor of non-inflammatory arthritis. Another thing is patient might complain of joint pain, but there is no evidence of inflammation. There is no joint swelling, no tenderness, no warmth and redness. This condition is called arthralgia, and it is typically seen in fibromyalgia and maybe even in early stages of rheumatoid arthritis. So after this, the next thing is to see the pattern of pain or joint involvement. Now, mode of onset is very important. If you have an acute onset, remember, infective arthritis can be the cause. It can be because of trauma. It can be because of gout. If you have an insidious onset, rheumatoid arthritis, osteoarthritis, and spondyloarthropathies are common examples of this. Then duration of pain. This is very important. If you have duration of pain is less than 6 weeks, we call it an acute arthritis. And if it is more than 6 weeks, we call it chronic arthritis. The main importance of this is if a patient has pain which is less than 6 weeks, it might be to a self-limiting illness like a viral arthritis. And one should not investigate unnecessarily unless there is a systemic involvement or there is something life-threatening. Next thing is to look at the number of joints involved. If you have a monoarticular joint involved, think of trauma, gout, septic arthritis. If you have oligoarticular involvement, that is 2 to 4 joints, think of spondyloarthropathies and psoriasis. If you have polyarticular joint, that is more than 5 joints involved, then think of RA, SLE, and vasculitis. But remember, nothing is absolute in rheumatology. The symptoms might change, the number of joints might increase. For example, you might have just one involvement of one joint in gout initial stages. Later on, you can have polyarthritis. Similarly, rheumatoid arthritis may begin with the oligoarticular joint involvement, and later on, as the disease progresses, you tend to have polyarthritis. Next thing, which is very important, as I mentioned before, symmetry. If you have a symmetrical joint involvement, then think of rheumatoid arthritis, think of SLE, systemic sclerosis. Asymmetrical joint involvement would suggest gout or spondyloarthropathy. Small and large joint involvement. Well, we all know rheumatoid arthritis, SLE, psoriasis can involve both small and large joints. But in spondyloarthropathy, you mainly have large joint involvement. Type of joint involvement is again very important, and one should take care of it when you are examining a patient. If you have the metacarpopharyngeal joint or proximal interpharyngeal joint, rheumatoid arthritis should be your first diagnosis. But if you have a distal interpharyngeal joint involvement, think of osteoarthritis and psoriatic as the cause. Similarly, remember, in the spinal involvement, except for cervical spine, is not common in rheumatoid arthritis. If you have lower spine involvement, think of spondyloarthropathies. Then is upper or lower limb involvement. One should remember rheumatoid arthritis, SLE, psoriasis can involve both upper and lower limb. But lower limb involvement is typically seen in Lyme's arthritis, it is seen in spondyloarthropathies, and also in gout or osteoarthritis. Another important factor which should be considered is sequence of involvement. There can be three basic patterns: additive, intermittent, and migratory. Just to refresh your memory, additive pattern is when you have a single joint involvement and after some time another joint is involved and the inflammation in the first joint persists. This pattern is typically seen in patients with rheumatoid arthritis, SLE, and spondyloarthropathy. Intermittent arthritis is when you have a joint involvement with inflammation and in between the patient is absolutely fine. We all know this is seen in patients with gout and Behçet's syndrome. Migratory arthritis, another unique pattern of involvement in which you have a single joint involvement, evolves over 1.5 days, then another joint is involved, and so on, and then another joint. This is typically, we all know, seen in rheumatic fever, gonococcal arthritis, and viral arthritis. Then type of musculoskeletal involvement is also very important. Spondyloarthropathies are known to cause typical three types of involvement. One is dactylitis, which is sausage-shaped digits, as we see in psoriasis. You can have inflammation of Achilles tendon or enthesis, swelling of enthesis. This is enthesitis. And then low back pain, which is seen in spondyloarthropathy. I have few slides which I'll come to after some time. After we have noticed and studied the type of joint involvement, it is very important to look for extra articular joint involvement, both in history and examination. This gives us an idea of the disease we are dealing with and helps us to reach a diagnosis. Well, just see, this list is very extensive, but just to give you some idea, due to paucity of time, I'll just talk some common features. Skin and nails involvement. Psoriasis. We all know psoriasis is associated with typical skin lesions. You can have pitting of nails and hyperkeratosis. But remember, psoriasis is very common. If you have a psoriatic lesion, do not think it is only because of psoriasis. Remember, it can be an isolated finding. Look for other causes too. Parvo B19 infection causes an acute polyarthritis, and typical you have a slapped cheek rash there, or you have a lacy erythematous maculopapular rash. We all know malar rash is seen in SLE. We are again aware nodules can be seen in rheumatoid arthritis and gout. Skin lesions of dermatomyositis are known to all of us. You have heliotrope rash, Scholl sign, we have V sign and Gottman's papules. These things I'm just refreshing for your knowledge. Eye involvement again is very common in and can cause different types of arthritis. If you have inferior uveitis, think of spondyloarthropathies. If you have panuveitis or posterior uveitis, think of Behçet's disease. If you have granulomatous uveitis, think of TB and sarcoidosis. Episcleritis or scleritis, remember rheumatoid arthritis is the cause. Dry eye, think of Sjogren's. Conjunctivitis, reactive arthritis has to be considered. Peripheral lymphadenopathy. If you get peripheral lymphadenopathy and polyarthritis, think of SLE, adult onset, and lymphoma. Similarly, hepatosplenomegaly, SLE, and adult onset Still's disease has to be considered. Urogenital abnormality, think of SLE and vasculitis. If there is an active glomerular sediment, which is seen by, if you have proteinuria, you have hematuria, think of SLE and vasculitis as a cause. And remember, chlamydial infection can also cause reactive arthritis and can result in polyarthritis, or more commonly oligoarthritis. Gastrointestinal system can, if you have dysphagia, think of scleroderma, polymyositis as a cause of your polyarthritis. If you have diarrhea, remember Campylobacter, Shigella, Salmonella, all of these can cause reactive arthritis, along with IBD. If you have diarrhea with perianal disease, think of IBD. And you always remember to ask patient if he's having any blood in stools. Cardiovascular system. If you have bradycardia, think of hypothyroidism. If you have a new onset murmur, think of rheumatic fever, think of subacute bacterial endocarditis, mitral murmur of mitral regurgitation, think of rheumatic fever. Aortic dilatation or aortic regurgitation, think of spondyloarthropathy or syphilis. If you have absent pulses, think of arthritis. Similarly, lung may be involved in various forms like pleuritis, effusions, lung nodules, ILD, and pulmonary hypertension. So whenever you have a patient with polyarthritis, look at, in fact, you have to be like a detective. See all these features and try to fit in. And remember, one feature will not make a diagnosis. You have to look in totality. Miscellaneous questions which one must ask. Age is an important factor. Remember, there are certain diseases which are much common in a younger age group. For example, rheumatic fever, rheumatoid arthritis, SLE are more common in a younger age group, whereas polymyalgia rheumatica, gout, and osteoarthritis are seen in elderly age group. Sex again plays an important role. We all know SLE is 9 times more common in premenopausal women. Similarly, rheumatoid arthritis may be 4 to 5 times more common in premenopausal women. And after menopause, the incidence becomes more or less the same. Even in Parvo B19 virus, studies have shown ladies are more prone to polyarthritis as compared to men. Then gout. We all know gout is virtually not seen in premenopausal women unless this is associated chronic renal failure or some malignancy. And gout is usually seen after menopause in ladies. Race is again an important factor. In whites, polymyalgia rheumatica is more common. In blacks, SLE and sarcoidosis is more common. Family history, we all are aware, ankylosing spondylitis, rheumatoid arthritis can all run in families. Remember, another important thing, we have a whole lot of drugs now. And if you can't find anything, think of drugs as a cause. Immune check inhibitors, clindamycin, INH, pyrazinamide, antithyroid drugs. These are common drugs which we use commonly and can present with polyarthritis. History of infections, I've already mentioned. You can have reactive arthritis due to chlamydial infections or because of Salmonella, Shigella, Campylobacter infections. Syphilis and Lyme's disease can also cause arthritis. Malignancy is another important component. In this, you have you have weight loss, fever, and generalized debility, and it's usually more acute. And this can occur in hematolymphoid malignancies, and also in CA breast and CA lung, besides others. So these are the things you must keep in mind whenever you see a patient with arthritis. Well, we have the next speaker, Dr. Uma, who will be talking about lab investigations, but I'll just like to touch and be very brief about the lab investigations, just a few points. I will not spend much time. Well, whenever we have a patient with polyarthritis, one should get a CBC, LFT, RFT urine return, which we always get. Now, these will give us an idea whether we are dealing with a systemic disease. For example, you have inactive urinary sediment with proteinuria, hematuria, and polyarthritis. Think of SLE or vasculitis. If you have LFT, which is deranged, think of diseases of liver, which can cause polyarthritis. Similarly, CBC, if it's TLC is very high, think of an infective process, or if PBF shows abnormal cells, think of a malignancy. Inflammatory markers. Now, these are used right and left to differentiate between inflammatory arthritis and non-inflammatory arthritis, but they can be confusing. Many times it has been seen patients with established rheumatoid disease have inflammatory markers which are normal. And one must remember inflammatory markers like ESR can be increased as we age with infection, renal disease, dysproteinemias, and anemias. So isolated, ESR increase, you cannot make a diagnosis of inflammatory arthritis. They do suggest we're dealing with inflammatory arthritis. Rheumatoid factor, again, a very widely used test, but unfortunately, we all are aware they may be negative in up to 30% of established rheumatoid arthritis. But if you add to confuse things further, one should remember they can be present in 5 to 10% of normal people, besides being positive in infections with malignancies and other autoimmune diseases. But remember, if you have a high titer of rheumatoid arthritis, chances of rheumatoid arthritis are higher. Anti-CCP antibodies, again, a better test than rheumatoid factor, more sensitive and predicts erosive disease more, and higher the titer, more significant. If both these are positive, the chances of rheumatoid arthritis are high. AN, one of a very widely used test, but again, I would just like to remind everyone, it has very high sensitivity, but very low specificity. Means if it is negative, you can rule out SLE. But if it is positive, it may be positive in 5 to 10% of normal people, and besides other autoimmune diseases. And if it is positive, if the things don't fit into SLE, then you have to investigate, get other auto antibodies to make a diagnosis. Serum uric acid, one of the most widely misused tests. We all know uric acid can be, and we all have seen, is normal in acute cases, many times normal in cases of acute gout. And always remember, asymptomatic hyperuricemia is very, very common. So if you have a high uric acid, don't make a diagnosis of polyarthritis unless you have ruled out other conditions and there are other features to suggest that we are dealing with crystal deposition diseases. HLA-B27, a test which is widely used to make a diagnosis of spondyloarthropathies. But remember, 8% of normal people in whites can have HLA-B27, and only 1% of people have, in normal population, have spondyloarthropathy. So take it with a pinch of salt when HLA-B27 is positive. Synovial fluid analysis, again, a useful test to make a diagnosis of hemarthrosis, differentiate between inflammatory and non-inflammatory disorders and crystal deposition diseases. If you have less than 2,000 cells with less than 25% neutrophils, think of a non-inflammatory state. More than 2,000 to 220,000 cells, think of an inflammatory state. And if you have more than 20,000, think of a sepsis. But remember, some people consider more than 50,000 or even 1 lakh as sepsis. But because of widely use of antibiotics, or even in gonococcal infections, one may have infective arthritis even at a younger level. So some people take 20,000 as a cutoff level. Plain X-ray films are useful because they pick up typical lesions of osteoarthritis and rheumatoid arthritis if the disease has been present for some time. Plus, they may help you to make a diagnosis of osteomyelitis or fractures. But remember, you might have a patient with osteoarthritis with a severe disease, X-ray is normal, and vice versa. X-rays may be very bad, patient may be asymptomatic. Ultrasound joints, a new modality which is being used now to detect early synovitis, to pick up crystal deposition. MRI, again used to pick up early sacroiliitis, but not used very regularly. But if there's a doubt, MRI may be used. PET-CT, again used for large vesicle vasculitis, or if you're thinking of a malignancy. Synovial biopsy, a useful test if you're thinking of sarcoidosis or tuberculosis. Plus, besides synovial biopsy, one may need to do a kidney biopsy, skin biopsy if you're thinking of diseases like a kidney disease or some skin disease causing polyarthritis. I have not talked much about because next speaker is going to probably talk in detail. Well, I have few slides just to wind up. Because of paucity of time, I'll just hurry up. Rheumatoid typical, the first slide, we all know a typical rheumatoid arthritis patient with metacarpophalangeal joint involvement, typical deformities. The second slide shows rheumatoid nodules. Third slide, erythema nodosum, we are all aware of. Fourth slide, scleroderma, typical pinched faces, we are aware of. Then Gottron papules, dermatomyositis. Then I actually can't see the slides on the side because the picture. Well, they're all, they show scleroderma. Let's try to get the slides inside. I don't remember what the slides are there. Okay, so scleroderma and then Gottron's papules, which I've already talked about. Then the next slide, malar rash, we're all aware of, which is seen in SLE, swollen Achilles tendon, which is a feature of spondyloarthropathies, and psoriatic nails, which shows a nail pitting. then generalized morphia, scleroderma, sausage digit seen in psoriasis. If you notice, you can appreciate the swollen fingers. In this, besides the joint, there is involvement of the surrounding structures. Well, this is at glance. This is joint pain. We make a diagnosis of arthritis. Then you decide whether it is monoarthritis, oligoarthritis, polyarthritis. Polyarthritis can be inflammatory, non-inflammatory, as I've talked about, and the causes of chronic arthritis, acute and OA. Well, this is all I had. Well, I'd just like to sum up. Joint pain, a cardinal symptom in rheumatology. It requires a good history taking, physical examination, and a judicious use of investigations. And remember, investigations should be only used to corroborate with your history taking and physical examination, and should not be used to make the diagnosis. Thank you for patiently listening.
Thank you very much, Dr. Satija. Such a fantastic presentation on arthritis. Now, I will request Dr. MP Singh to put the question answers in the last and take up the next speaker, please.
The next speaker is none other than Dr. Uma Kumar. I'd request Dr. MPS Chawla sir to introduce her and conduct the rest of the proceedings.
Well, thank you, Dr. MP Singh. Basically, I think there are two branches. One is rheumatology, another is neurology, where 95% of the job is done by history and examination only, and 5% of the job is left to the investigations. So I think Uma is left with 5% of the job. She's an accomplished speaker, and she founded the Department of Rheumatology in AIIMS, and she was the first head of department there. She has more than 150 publications to her credit, and she is, one of the subspecialists who talks sense. So over to you, Uma.
Good evening, everyone. Hello, am I audible?
Yeah, Uma. Yes, Uma,
Yes,
you are
yes.
audible. Please,
Audible.
All right.
please
My
proceed.
screen is visible.
Not yet. Mm.
Is
Are
it
you sharing
visible?
it?
Yes, I have shared.
Yeah,
Yes.
it is okay. Then start. Let us see.
Is it visible now?
Yes.
It is visible. Go ahead, Uma. Go ahead.
All right. Yeah. So at the outset, I would like to thank Iacm for giving me this opportunity. And it's my proud privilege to deliberate today in presence of Bhishma Pitamaha, as I call Dr. Parekh sir, and Dr. Girish Mathur, my teacher, Professor M.M. Singh, because I did my MD from Agra, and 92 was the year when IACM was started, and we were in first year. So I have a very close connect with this particular association. Thank you, Dr. Tarun Satiza, who has really made my job easier. So I will be trying to finish my presentation in next 15 minutes. So as you all know, rheumatology is a strong clinical science, where history and examination contribute by 95%. And it is very important to acknowledge at this stage that lab investigation cannot substitute for good clinical assessment. And if a test is carried out without clinical justification, then it's likely to produce false positive reports, confusing both the patient and the doctor. And we all know performance of test depends heavily on pre-test probability. So in rheumatology in particular, it's important to order tests when we are considering a particular diagnosis. All our diseases are multi-system diseases, and there are close to 60 conditions where patients can present with polyarthritis. And whenever we are ordering investigations, we have to have some differential in our mind. So as you can, just a sec. Yeah, where is my presentation gone? Yes. So as you can see here, for the sake of convenience, we divide the investigations into 4 divisions. One is basic routine investigations, which are to be done in all the patients. They are usually hemogram, inflammatory markers like ESR, CRP, liver function test, kidney function test, vitamin D levels, because it is known by now that vitamin D predisposes to autoimmune diseases and also brings about flares in controlled autoimmune diseases on treatment. And then urine examination is also very, very important in our set of patients. After that, we divide investigations into 3 categories. One is assisting the diagnosis. Second is to know the extent of the disease. And third is assessing the comorbidities, because in all our conditions, there is low-grade inflammation. Sometimes, despite patient being on treatment and which is not manifesting, can result in multiple comorbidities like diabetes, hypertension, stroke, coronary artery disease, and ultimately reducing the lifespan of the patient. So what are the investigations included for the diagnosis? One is rheumatoid factor, anti-CCP, ANA, extractable nuclear antigens, complements, particularly C3 and C4, ANCA, anti-PR3, which is anti-proteinase 3, anti-MPO, myositis profile, CPK-LDH, and IgG4 diseases are also prevalent. So IgG4 related investigations, APLA, which is antiphospholipid antibody as positivity, which is like lupus anticoagulant, anti-beta 2 GP1, and anti-cardiolipin antibodies, IgG and IgM, IgA if the test is available. Then the Coombs test. These are the immunological investigations which can be ordered in certain specific situations. Then the radiology, which is commonly used as X-ray both hands. I would like to bring out one point here, that it is not important to order investigations of all the joints which are inflamed. So why do we do X-ray both hands? To look for, to make the diagnosis of rheumatoid arthritis, or to look for erosions, to look for other radiological changes, or any other joint where we are thinking of doing some intervention. For example, if one joint is damaged and requires replacement, then particular joint X-ray. Chest X-ray is important because, as I said, our diseases are multicentric diseases. Then CT, MRI, PET, as Dr. Satija has talked about, angiography, ultrasound. Then the histological diagnosis we get from skin biopsy, kidney biopsy, nerves, muscle, minor salivary gland. So I think almost all these are done by physicians. And at our center, we also are doing all such biopsies. Then how do we assess the extent? For that, again, as I said, we need to look at a bone marrow involvement. So it could be hemogram. Patient can have autoimmune hemolytic anemia. LFT, KFT, urine examination helps in assessing the extent of the disease. Radiology helps in assessing the extent of the disease. And we decide these investigations based on the clinical findings. If the patient has no clinical finding in the chest, there's no need to do the X-ray until unless that fits into our differential diagnosis. If you're thinking of sarcoid, and even if patient is not manifesting, we need to do the chest X-ray. Or we are thinking of GPA, which is granulomatosis polyangiitis. Even if patient is not symptomatic for lungs, then also we need to do, because sometimes we can have nodular opacities there. Similarly, other biopsies, as I just mentioned, can help in knowing the extent of the disease. By writing so many, I don't mean that all these tissues are to be biopsied. If patient has kidney involvement, then obviously kidney biopsy. If patient has, for example, ANCA-associated vasculitis, patient has neurological manifestation, patient has renal manifestation, there's no need to do the nerve biopsy as well as the kidney biopsy together, because we just need that for diagnosis. So even kidney biopsy is revealing ANCA-associated vasculitis is fine, and patient would be treated accordingly. Then to look for comorbidities, we do a lipid profile, HbA1c, blood glucose, DEXA selectively. It's not done in all patients. If the patient is more than 50 years of age, or there is long-standing inflammatory polyarthritis, or patient is postmenopausal, has other risk factors, then DEXA can be ordered. Or we are anticipating that patient is postmenopausal and would be on steroids for a longer period of time, then we need to have baseline DEXA. ECG in select few cases, or echocardiography, not done in all patients. I'll give you a few examples. A lady who's 32-year-old presents with polyarthritis of 3 months duration, has small joints of hands and wrist involvement, which is symmetrical, additive, with early morning stiffness of 15 minutes duration, as you can see in the picture. There is dactylitis of the right index finger. There are nail changes. So patient has polyarthritis, dactylitis, and nail changes. What comes? And patient also has family history of psoriasis. So no guesses, it seems more like psoriatic arthritis, but sometimes psoriatic arthritis and rheumatoid arthritis can coexist. So even if somebody does rheumatoid factor and anti-CCP in this set of patients, it's justifiable. But one needs to know that anti-CCP can be falsely positive in psoriatic arthritis patients. Then basic investigations are, as I told you, would be done in all the patients. Immunological investigation, we actually don't need, except RF anti-CCP if we are thinking of rheumatoid along with psoriatic arthritis, which is a very, very rare combination. Radiology, yes, X-ray both hands required. No biopsy is needed in this patient. For looking at the accident, no investigation is required, because psoriatic arthritis usually confines itself to the joint. And then for comorbidities, yes. We need to do a lipid profile. Metabolic syndrome is very common in these patients, so investigations related to that. DEXA and ECG echo again selectively in patients. So as in this patient who had psoriatic arthritis but had anti-CCP positive, as Dr. Satija has also talked about the false positivity of various immunological tests. So rheumatoid factor can be falsely positive in a whole lot of conditions, particularly in connective tissue diseases, infections, and even in aging, rheumatoid factor can be positive. Anti-CCP antibody is very, very specific, but we do see its positivity in lupus, psoriatic arthritis, even in JIA that is reported positivity. So there's another patient who had polyarthritis of small joints of hands, which is symmetrical for 4 months duration, has proximal muscle weakness, has photodermatitis, heliotrope rash, as you can see in this picture, periorbital edema with lilac colored rash here. Patient also had basal crepitations, has Gottron papules. What could be the differential here? Two. One, dermatomyositis. Another one is overlap syndrome. Polyarthritis can occur in dermatomyositis in close to 40% of patients, but it could be overlap also, where rheumatoid arthritis and dermatomyositis is occurring together. So our investigations also would be targeted accordingly. Going to the same flow diagram, where in this patient particularly we'll do the RF, anti-CCP, and ANA, because ANA is also seen to be positive in these patients in 40 to 60% cases. Then radiology, obviously X-ray both hands, because patient has polyarthritis and we are suspecting rheumatoid arthritis overlap in this patient. Biopsy, yes, muscle biopsy would be required for this patient to make the diagnosis. Some people recommend doing MRI in all the patients, and although a muscle biopsy is not indicated, but I because MRI can only show you muscle edema, it cannot classify myositis. It could be polymyositis, dermatomyositis, or inclusion body myositis, or necrotizing myositis. So that need muscle biopsy. EMG. Then again, in these set of patients, besides what we said for comorbidities, we need to screen patients for malignancies. And for malignancy screening, we do not need to do the PET scan. It costs huge 25,000 in the private setup. So why to make patients spend so much? We'll have to keep our patients' economic condition also in mind when we are treating medical condition. So screening for malignancy, usually we do with ENT evaluation to rule out nasopharyngeal carcinoma, TSH, ultrasound breast if the lady is less than 50 years of age, or mammography if more than 50, pap smear, stool local blood, and ultrasound pelvis to look for adnexa. So just a word about MRI and muscle biopsy. As I said, that muscle biopsy remain the gold standard, and muscle can show some hyperechoic areas in certain conditions, like if the person has had strenuous exercise, you can show hyperechogenic areas, or certain other conditions where it can actually mimic myositis. So one has to be very, very careful. And even for selection of muscle, it is not required, because MRI might show uptake in muscles which are not approachable, amenable to biopsy. Then again, that would be useless. So we recommend do MRI only in certain specific situations if required. Muscle biopsy, although invasive, but it's a very safe procedure to do in right setting. This is another patient, 45-year-old male, polyarthritis, which is asymmetrical, involving both large and small joints, has significant early morning stiffness. I don't know why this animation is not working. It is overlapping over it. So what one would think, it could be rheumatoid, but one has to pay attention that it is asymmetric polyarthritis, and it is in a male. Rheumatoid is more common in females. So on investigations, patient had polymorphonuclear leukocytosis, thrombocytosis, inflammatory markers were elevated. Platelets and leukocytes sometimes indicate ongoing inflammation, but normally we don't get it. Where do we get it? In primary systemic necrotizing vasculitis. So that raises suspicion. And then patient was rheumatoid factor anti-CCP negative. Anchor, I can't see at the back of this. Animation is not. Can you see the animation, please?
No, animation is not working.
Oh, yeah.
It's fine. No problems. You just carry on.
All right. So patient then had a TSH normal, because 60% of our autoimmune patients have hypothyroidism. So it's can be added to the list of investigations. Urine examination, as I said, must be done in all patients where renal involvement is suspected or not suspected. So in this patient, there were RBCs, WBCs, and proteinuria. 24-hour urinary proteins were also elevated. Cytoplasmic ANCA came positive. NT-PR3 was elevated. So no guesses, but the diagnosis was ANCA-associated vasculitis. But patient had no other manifestation. But despite that, we went ahead to do X-ray paranasal sinuses, because patients can have pansinusitis. HRCT chest, X-ray was normal. Sometimes X-ray may not reveal small nodules, so it's very justified to do HRCT in this setting. ANCA can also be falsely positive, but now these days the recommendation is to do ANCA by immunofluorescence as well as by ELISA. And one needs to remember that only two antigens, PR3 and MPO, have got some clinical relevance other antigens have not shown till date any clinical relevance. But most commonly we get P ANCA positivity, and sometimes high titer ANA can also mimic P ANCA. So one has to be very, very careful in interpreting the results, keeping in mind the patient's clinical condition. Recommendation in current time says that first one must do a PR3 ANCA and MPO ANCA by ELISA, and if that is negative, then one can order immunofluorescence. But to save time, because every time patient comes, spend some money, so we can order ANCA by immunofluorescence and anti-PR3 and anti-MPO by ELISA. And despite everything, 20% of the patients, they remain negative for both. If we club both together, the specificity increases to 99%, and the positive predictive value of the test goes up by 88%. And there are certain conditions where one can order ANCA, and they are like glomerulonephritis, pulmonary hemorrhage, cutaneous vasculitis with systemic features, multiple lung nodules, chronic obstructive airway disease, sinusitis, subglottic tracheal stenosis, monocytis multiplex, retroorbital masses, and scleritis, even if patient is not having other manifestations. This is another case where it was 45-year-old male with polyarthritis involving small joints of hands, closely mimicking rheumatoid with significant early morning stiffness, but the patient had basal crepitations, differential changes, because at the very outset, getting interstitial lung disease in rheumatoid is very, very less. It's close to just 10%. So diagnosis was sarcoidosis, and the second differential was RA with ILD. Rheumatoid factor anti-CCP were both positive. X-ray, both hands had shown swelling around the proximal interphalangeal joint, but patient had hilar lymphadenopathy on chest X-ray because we had sarcoidosis in our mind for this patient, and CT revealed hilar lymphadenopathy with interstitial lung disease. Serum calcium was elevated, ACE was increased. So patient had two conditions occurring together. One was sarcoidosis and the rheumatoid arthritis as well. Had the X-ray not done or the differential of sarcoid was not kept in mind, sarcoid diagnosis would have got missed. ESR, and now coming to ANA, which is supposed to be the screening investigations in connective tissue diseases diagnosis, and it's called the ESR of autoimmunity. And all of you know it can be positive in all connective tissue diseases and other non-rheumatological conditions as well. So it has to be interpreted very, very carefully. As was said, I don't know why it's getting moved so fast. As was told that ANA can be falsely positive in a good number of patients. That all depends on the titer. If the patient has 1:40 titer, 32% of the normal population had ANCA ANA positivity. And as the titers go up, the specificity goes up. So if the titers are high, more than 320, then the chances are it is maybe true positive. A word about ENA, extractable nuclear antigen, that is also a very commonly ordered test, but that has to be ordered only when we are thinking of certain conditions which fit into the spectrum of extractable nuclear antigen, because this is an expensive test. Yeah, this is, I told you that. And then we sometimes ANA can be positive in other conditions, and ENA is negative. That can give us clue that this condition is not related to ANA. And then ENA can be positive without ANA being positive. It happens in Sjogren syndrome, where anti-Rho, anti-La antigens are actually very deep-seated and they are very fragile, so may not be picked up. So if you are suspecting Sjogren syndrome and ANA is negative, then anti-Rho, anti-La antibodies must be ordered. Anti-dsDNA is supposed to be very specific for lupus. And then another case where 42-year-old male had polyarthritis. I'm sure you'd be able to diagnose this patient, but looking at the distance, it looked like rheumatoid arthritis. But in fact, this patient had these big nodules around the joint. So routine investigations were done. They were all normal. Uric acid was elevated, and patient was investigated for presence of comorbidities. And as you can look at the X-ray, patient had deep overhanging ulcers. Margins are overhanging, which is very classical of gouty arthritis. As was talked about, that ultrasound, muscular ultrasound has become the bedside procedure these days, and it helps us in actually looking for subclinical inflammation in patients, and also in diagnosing many soft tissue inflammations. This is here, you see the double contour sign, which is positive in gouty arthritis. Crystal studies, yes, should be done only when indicated. There is no role of getting, sugar and proteins done. Quite frequently, we see that even sugar proteins are ordered in synovial fluid. What we need to look at is crystal studies and cell count, gram stain in cultures when we are suspecting septic arthritis. So uric acid elevation is not diagnostic of any conditions, and 10% of the patient with acute gout can have normal uric acid. ASO carries no meaning in our set of patients because they are adults, more than 15 years of age. So it's better not to order ASO titers in patients who are presenting with polyarthritis. And there's nothing called panel of investigations. It should be completely condemned and abandoned. So I'll conclude by this another case, 25-year-old female, hypertensive, asymmetrical, small joint of hand polyarthritis, with significant early morning stiffness of 2 months duration, had raised inflammatory markers. Rheumatoid factor was strongly positive. So this patient was labeled as having rheumatoid arthritis. But patient, when started on methotrexate, developed transaminitis and other manifestations. Tingling numbness in left hand. Methotrexate was stopped. Patient was investigated, was found to be having HBV positive and monocytic multiplex on nerve conduction, nerve biopsy. So patient had polyarthritis nodosa. So it's very important to order investigation judiciously in a set of patients. There are no recommended investigations for a particular clinical diagnosis in rheumatology practice. Then search for autoantibodies should only be made if we are suspecting any autoimmune disease. Otherwise, false positivity will only trouble you more than the diagnosis of the patient. And most important thing is that don't be in a hurry to diagnose the patient. Patient can evolve over the period of time. So one can always write that polyarthritis under evaluation, and patient can be started or treatment in the meantime. Thank you so much, and happy Holi to you all.
So thank you, Ma. I think you have done justice to this topic. So the message is loud and clear. Don't run after autoantibodies. You don't diagnose, in rheumatology on the basis of the whole clinical text is very important. And I think MP Singh, you can take over and move on to the third speaker, please.
Yeah, I'll now request Dr. H.S. Pathak sir to introduce and welcome Dr. Aradhana Singh for her presentation.
After two brilliant talks from Kumar regarding research and investigation, we are now proceeding for treatment of polyarthritis. And it is my pleasure to introduce another brilliant speaker, Professor Aradhana Singh, who is Professor Founder Head, Department of Rheumatology, Clinical Immunology in Jaipur. She President Rajasthan Association, and she has a number of feathers in her cap. She was awarded Excellence Award for Academics 2018, Best Faculty Award 2019 in the Clinical Case Presentation Jaipur. She has also been awarded with Excellence memorial oration, and she has a number of publications. So with this introduction, I hand over the podium to Professor Alar Rana Singh.
Good evening, all. At the outset, I would like to thank our mentor, Dr. Parik sir, Dr. Girish sir, and my teacher in UGZ, Professor Singh sir, because I did my undergrad from SN Medical College, Agra. So it's been a wonderful and opportunity, and I'm highly, highly privileged. So the topic of management of polyarthritis is like, I have nothing to disclose basically. So management of polyarthritis, it's like saying, Chalo Bharat Desh. So, but where Bharat? So instead of saying ki Chalo Rajasthan, or in Rajasthan, Chalo Jaipur, or in Jaipur, it's like Chalo Bagru, or maybe some village or some gully. So it's basically a very broad term to tackle with. So at the end of this talk, we should be able to clear our dilemmas, like when to treat with what is treat to target, when to uptright, and with what we should uptright it, what to do with the flare, what are the comorbidities, or what to do with the infections like tuberculosis. Then what to do when patient is pregnant or she's planning to conceive, and what to do if patient is undergoing surgery, and when to taper the medicine or stop. So we should be able to clear it. To set the talk, I think we should be able to tell the management of seronegative, seropositive RAs, spondyloarthropathies, special condition like malignancy or infection, and then we'll conclude our talk. Polyarthritis, I think I need not to tell because it was brilliantly covered by Dr. Satija. And the 5 causes symmetrical arthritis, no marks for actually answering this because it has already been covered. So evolution of rheumatoid arthritis over a period was a remarkable story of success. Starting from aspirin and gold in 90s and 1930s to tofacitinib, baricitinib, JAK inhibitors or biologicals in late 2020, it was a remarkable progress. So it was earlier, it was a monotherapy, then it was we call it methotrexate therapy. Then we combine methotrexate with biologicals. So evolution was marvelous. So before starting the management, we should look for the poor prognostic factor, like what is the disease activity at the time of presentation? What are the extra-articular manifestation? Is there any nodule? Is the patient smoker? Is the patient obese? Because obese is a predictor of disease activity. Then patient is having erosions or not? What is the magnitude of ESR or CRP? RF is positive or not, and if positive, how big the magnitude is, anti-CCP positive, or whether they share the epitope or not. What happened? Sorry. So before this thing, we should also know about the disease activity. So they have already covered, like we should count the tender joint count, we should see the swollen joint count, and we should evaluate the physician evaluator global assessment or patient global assessment. That gives an idea how to start or how to continue with the medicine. Then what is important is how to assess the response of the management or treat to target to see that. So we should know about the functional classification of the disease. Is there any change in the visual analog scale, or there is a change in health assessment questionnaire, whether there is a change in EGA or change in disease activity indices. And we should always use a simple method or same tool every time you assess the response, like DAS28 or CDI. So if we see ULR criteria, so if the DAS28 ESR-CRP is less than 3.2, ULR say it is low disease activity or remission. If it is between 3.2 to 5, it is moderate activity. If there is a decline in DAS28 for more than 1.2, it is a good remission, or moderate, it is 0.6 to 1.2. So the basic principle remains the same. It should be a shared decision between the physician and the patient. then always look for the contraindication of the disease treatment. And most importantly, do not forget to ask about the marital status of the patient, whether she's pregnant or wants pregnant, or she is using any family planning. So to see the treat to target, we should know the low disease activity, we should plan for remission, or we should reassess every 2 to 3 months based on the efficacy or tolerability. And non-pharmacotherapies should be given a due place in the treatment or management of the polyarthritis, like physiotherapies, occupational therapies, through CBT, make aware of all the patient help groups, and ergonomics should be taken care of. Stop smoking or tobacco if the patient is using all this. So we divide the treatment in 3 parts, like they have 3 categories. It is conventional DMARDs, it's biological DMARDs, or targeted synthetic DMARDs. In the conventional DMARDs, we all know it's methotrexate, leflunomide, sulfasalazine, or HCQ. In biologicals, we have anti-TNF, we have non-anti-TNF like IL-6 receptor inhibitors or B-cell depletion therapy. In the targeted synthetic DMARDs, we have tofacitinib, baricitinib, upadacitinib, or filgotinib. So let's see. A 45-year male was newly diagnosed with RA with DAS28 score 6.1 with functional class 2. So the common query is what to start. So it is monotherapy, we should start with methotrexate, or we should start from the triple therapy straight away because it's like hit hard and hit early. So it's like methotrexate, sulfasalazine, HCQ, or we should shift to JAK inhibitors or TNF or methotrexate. So 2019 EULAR management recommendations are, if you have made the clinical diagnosis of rheumatoid arthritis and there is no contraindication of methotrexate, you start with methotrexate and then combine it with the short term of glucocorticoid. But if it is somehow methotrexate is contraindicated, then you start with leflunomide and sulfasalazine plus glucocorticoid short-term therapy. If the patient improved in 3 months or achieved target 6 months, then you continue with it. Or if not, then you again combine other drugs plus short-term glucocorticoid therapy. If the patient is DMARD naive and the DAS score is moderate to severe, the strong recommendation by ACR 2021 is methotrexate should be started, followed by HCQ, sulfasalazine, or biological DMARDs, or targeted synthetic DMARDs. Then steroid can be given, but it should not be given for more than 3 months. Then if there is some conditions applied, then methotrexate is preferred over leflunomide, or dual or triple conventional DMARD should be started. Or methotrexate plus targeted like tofacitinib plus steroid, but less than or equal to 3 months. So steroid should not be given for long. If the disease activity is low and patient is DMARD naive and DAS is less than or equal to 3.2, then the condition is that you prefer HCQ over methotrexate or methotrexate over sulfasalazine, or if these are not to be given, then methotrexate should be preferred over leflunomide. That's ACR 2021 criteria. So about methotrexate, it is like our experience that around 70% of the patient, they respond to the methotrexate, and trials also support this. In Lancet 2002, out of 1240 patients, 582 on methotrexate, there was a decrease in mortality hazard ratio by 0.4. In arthritis and rheumatism 2013, they had produced 5,000 patient data over a 1-year methotrexate therapy. So there was a decrease in mortality by 70%. So methotrexate kind of wonder drug for that. So if the patient is intolerable to oral, then you split the dose. Split the dose means if you want to give 25%, you split the dose like 10 milligram in the morning and 15 milligram in the evening, same day. But and patient is not able to take, then you switch to the injectable or you increase the folic acid or antiemetic. And if your target is not achieved, then you try the subcutaneous instead of adding or switching to another DMARDs or biologicals, you try subcutaneous. So next what? Like 45-year-old gentleman with rheumatic arthritis with DAS 28 3.6, and he was on methotrexate 20 milligram per week with HCQ 300 milligram per day. In such cases, what should we do? Shall we wait for next 6 months, or we add another DMARS because DAS is still high? So you call it methotrexate failure or not? If it is a methotrexate failure, patient is still not responding from 3 to 6 months. So either you have to add the therapy, or you want to change the therapy, or you want to start with the conventional, continue with conventional, or you change to the biological. So if the methotrexate generally 60% they respond, or 30% they had low disease activity, only 5 to 10% have primary resistance to the methotrexate. So dose optimization is very important, 25 milligram per week. So generally what we see in daily practice, we see 7 milligram or 15 milligrams. So the proper dosing is very important before labeling the patient as methotrexate failure. So if it is there, then adding another is important, or change the therapy is important. So best is additional is better and had better radiographic score, and there is a less chance of switching to therapies. So in 2010, methotrexate etanercept was combined, but adding etanercept was better than giving alone methotrexate. So adding is always better. So what to add now? So if the poor prognostic factor is there, then biological DMARDs or synthetic DMARDs can be added. ACR says conditionally that add biological or targeted synthetic DMARDs like methotrexate or triple therapy, sulfasalazine or HCQ. ULR says if there is no poor prognostic factor, then add second conventional DMARDs. And as I said earlier also, they recommend continuous use of glucocorticoids. So what we do generally, if there is a biological adding, so we look at the finance because there's a costly affair. We need to see that factor also. Then look at the contraindication if it is there. Then there is always a query whether it is synthetic DMARD is better or conventional DMARD is better. So you need to take care of these two factors. So if finance is there, contraindications are there, it is better to add leflunomide or sulfasalazine to the methotrexate. And the best part is monitoring is important in such cases because cytopenias or fall in hemoglobin or transaminitis is very common. So biological DMARDs or targeted synthetic DMARDs as monotherapy, whether we should go for it or not. So data are there on IL-6 receptor inhibitors and targeted synthetic DMARDs, and not much it is there. So they always say that it should be combined with methotrexate, even if it is TNF inhibitors or B-cell depletion therapy, because it has got better retention rates and there is a lesser formation of HACA antibodies. So it is, if you have to taper it, so it is good to taper the expensive option because ours is a resource poor country. So that same 46-year-old male was assessed at 6 months. So it was shown low disease activity or remission. Then the question is now, shall I taper the medicine? That we will discuss later on. If the disease is still active, then change the biological DMARD or targeted synthetic DMARDs, or preference to the another class, like the mechanism of action should be different. Then how to decide which biological DMARDs or targeted synthetic DMARD? So as such, there is no specific recommendation that TNFI are better or superior than rituximab or JAK inhibitors. And as I said, finance and contraindication helps to decide which one to be used. So before initiating targeted synthetic DMARDs or biological DMARDs, there are a few guidelines, and we should screen for tuberculosis. We should screen for viral diseases like viral hepatitis. Then complete blood count should be there for, and then transaminitis should be ruled out, and serum creatinine. Remember the contraindication if there is heart failure, demyelinating disease, or active infection, we should avoid TNF inhibitors. If patient is pregnant or blood discs are there, methotrexate leflunomide should be avoided, or there is transaminitis. Retux should be avoided or contraindicated in presence of PML or active infection. And tocilizumab, if the patient is hypersensitive to it, or same, it applies, active infection is there, or DVT, demyelinating disease, or malignancy is there. In special situations like pulmonary disease, it is generally, everyone thinks that if there is a parenchymal disease, one should not give methotrexate, but it is not that. You should assess how active underlying lung disease is there, like ILD or AFib disease. You can give methotrexate. So does it warrant treatment, or it is an imaging finding? It's like accidental finding and patient is asymptomatic. Then also you should be very cautious about it, and you should be comfortable with it. So methotrexate is first reference in mild or asymptomatic patient as far as respiratory symptoms are there. But yes, if heart failure is there along with it, avoid TNF inhibitor or discontinue if they patient on TNF, they develop heart failure or dyspnea with NYHA class 3 and 4. Then if patient has got lymphoproliferative disease, naturally retux can be given. If patient is on hepatitis B positive, then first give antiviral disease. Keep on changing is not advisable, and there is not required that you keep on monitoring biochemically. Then biological DMARDs or targeted synthetic DMARDs can be given if they are positive, but with antiviral prophylaxis. If HBS is negative and viral core antibodies are positive, then you should go for LFT and viral loads. Then you decide with the treatment. In conditions where the infections are there, if serious infection is there within 12 months, then you should, conventional DMARDs are preferred over biologicals or targeted synthetic DMARDs or steroid. If non-tubercular mycobacteria is suspected, then conventional DMARDs, abatacept should be given, but steroid can be avoided. Then in case of special condition like pregnancy, these are few guidelines like methotrexate, leflunomide, mycophenolate, tofacitinib, all other biologicals should be avoided. Prednisolone, cyclosporine, NSAIDs in first and second trimester only, Retux and TNF inhibitor. Cyclophosphamide can be given if it is allowed and we have no other choice, but with cross finger. Otherwise, hydroxychloroquine, sulfasalazine, azathioprine, certolizumab, and colchicine, they are safe during pregnancy. During surgeries, it's a common question, what to do when the patient is undergoing surgery, like patient is going TKR or vaccination. So you can continue with conventional DMARDs. Biological DMARDs regarding, it depends on the duration of action. Like if the patient is on biological, so you should wait for at least 3 to 4 weeks. If patient is on a JAK inhibitor, then you should wait for 4 to 7 days before going for surgery. Then you should avoid live vaccine with biological DMARDs or targeted synthetic. So that's a long list. If the patient is on surgery, then sulfasalazine, methotrexate, there is no need to stop. You can go surgery anytime. And mycophenolate, azathioprine, tacrolimus, cyclosporine, you should go anytime. And if the patient is on Retux and other biological, you should wait for 4 to 6 months, or you should wait for at least minimum for 1 month. Then other biologicals, anti-TNF inhibitors, you should wait for 5 weeks or 9 weeks or 3 weeks. Otherwise, you can go ahead with surgery. Then mycophenolate, azathioprine, if lupus, they are taking for lupus and not very serious disease there. So you should wait for 1 week for after the last dose. If the patient has got difficult to treat RA, then compliance is very important. Compliance, you should always check for it, whether the patient is taking proper medicine. Then you look for damage or activity, go for USG to see the activity, then confirm the diagnosis, whether we are treating the right disease, rule out the mimics of RA. Then assess fibromyalgias, other disease activity should be then check vitamin B12 level, then vitamin D levels, so which aggravate the disease. Then non-pharmacological domain can be used, as I said earlier. So choose therapy with different mechanism. As I said, that always use, if you want to combine two, always go for another routes too. Then always assess the comorbidity, whether the patient is having infection or underlying malignancy. Intra-articular injection, if there is a single joint is troubling, then look for infection. Otherwise, you inject intra-articular steroid. And if patient is on anticoagulants, there is no contraindication, but you should avoid 3 months prior to the joint replacement. Monitoring, we should go for CBC, SGPT, serum creatinine every 2 to 3 months to see the effect of drugs. Regarding tapering, as we said, if the DAS score is less than 3.2, you wait for at least 6 months, then you continue it, and then dose reduction can be considered, but it has to be gradual. So which drug, if the patient is on triple therapy, so sulfasalazine is preferred over SCQ while tapering. Or if methotrexate and biological DMARDs are there, then methotrexate is preferred over biological synthetic DMARDs while tapering. In spondyloarthropathy, as I said, it's a broad term. So if it is a polyarticular like IBD, psoriatic or reactive arthritis, we have already read the definition of it. So ASS and ULR recommend the management of ankylosing spondylitis, whether axial or peripheral. So start with NSAIDs, sulfasalazine. If one joint is involved, inject with local corticosteroid, or anti-TNF inhibitors can be given. So exercise, rehabilitation, use of self-help group is very, very important. And if patient can undergo surgery if there is complete ankylosis of some joint. So non-pharmacological therapy we have already talked about. And about the symptomatic treatment, we have OSM group like methotrexate, Sazo, cyclosporine, leflunomide, apremilast. Then TNF inhibitors we have IL-12 and 23 inhibitors are there. The interleukin 17 inhibitors are there. The CTLA4, IgG, and JAK inhibitors. These are a whole spectrum of the medicine which we can use. In another SPA like psoriatic arthritis, it is methotrexate-based therapy is very effective. Plus, interleukin 17 inhibitors are very effective, and they are preferred over TNF inhibitors. In IBD, sulfasalazine is very effective along with TNF inhibitor. In reactive arthritis, you should wait with NSAIDs and intra-articular steroid. If it is chronic, then you give DMARDs. In chlamydia-induced reactive arthritis, role of antibiotics is very important. Then you should go for antibiotics. Then you check for uveitis, psoriasis, only skin involvement, or GI inflammation. Connective tissue disease is out of this thing because it's a part of polyarthritis. Otherwise, the main organ involvement are there. So we need to approach accordingly. Then monitor the side effects. And connective tissue disease, remember, we need to check pregnancy and lactation. In crystal arthropathy, if patient has got acute attack, you give NSAIDs, you start colchicine till the symptoms subside, or you can start a very short course of steroid, or you can inject it. If gout is there, then gout lowering agent is can be given if it is symptomatic and levels are more than 9 to 11, or tophi are there, nephrocalcinosis there. In case of refractory gout, chronic gout, we can give pegloticase 8 milligram IV every 2 weeks. In case of infection and polyarthritis, we already know if it is post-viral, we should wait with NSAIDs. If it is post-chikungunya and chronic, it is treated as rheumatoid arthritis. If it is post-vaccine or COVID polyarthritis, NSAID will low dose short course of steroid and should be given, and we should look for underlying rheumatoid or connective tissue disease. Then look for tuberculosis. Is this polyarticular tuberculosis, Ponsat disease, brucella, leprosis should be taken care of while diagnosing it because they are most commonly caused oligoarthritis. Then very rarely polyarticular septic arthritis is there in immunocompromised patients like HIV. Then take care of polymyalgia rheumatica if it can be a diagnosis. So low dose steroid and methotrexate can be given. Look for hematological malignancy and look for clues like weight loss, B symptoms, cytopenias, or inadequate response to the treatment. Then there is a term relapsing seronegative symmetrical synovitis with pitting edema. It can be a cause of polyarthritis. So you should always look for underlying malignancy in such cases. Then adult onset Still's disease, if you have diagnosed, then they respond to steroid and conventional DMARDs and IL-6 inhibitor or TNF inhibitors. So the key highlights is confirm the type and extraarticular manifestation, assess disease activity and prognostic factors, initiate treatment as early as possible because window of opportunity is very, very important in such case. Methotrexate, it is the anchor drug. If there is an inadequate response, combine conventional DMARDs with targeted synthetic DMARDs or biologicals, then treat to target should be our, it should be our target for low disease activity or remission and monitor disease activity every month initially and after 3 months with CBC, SGPT or serum creatinine. Thanks a lot. Thanks for your patience hearing.
I think MP, we can move on to question answer session. And
Yes,
I
sir,
would
we
like
can.
to,
We can.
I would
Sure.
like to congratulate Aradhana for, it was very complicated and she has covered almost everything in this. And this is very good that she has, most of the times there is a pharma pressure to write, biologics, and she has clearly told what is the place of biologics in the treatment of these diseases, and methotrexate remains the drug of choice. And one common thing that we usually are not doing is, one is that we are not using the adequate dose as she has explained. And second is if the patient fails on oral, then I think you should shift to subcutaneous before saying that this patient has failed methotrexate. So I think we can take the question answers, though all the three speakers, they have done an excellent job and most of the doubts, they must have been cleared already. But still, if there are any doubts, they are most welcome.
Are there any questions in chat box? Dr. MP, can we invite questions? 2-3 questions.
So there are 2 questions in chat box. The question number 1 is, can methotrexate be given in patients having underlying CHF in a patient of rheumatoid arthritis or psoriatic arthropathy?
Yeah, methotrexate absolutely can be given. Psoriatic, in fact, psoriatic arthritis respond very well to the methotrexate.
Good.
So I think that would be one condition where you would not like to use TNF inhibitors. Otherwise,
Exactly.
In psoriasis, TNF inhibitors, they have really changed the, kind of treatment. They're very effective. In fact,
Yeah.
improve the quality of
Methotrexate
life.
acts very well on the skin also, skin psoriatic
Exactly.
also. Yeah. And there is an urge to start when patient develops psoriasis with psoriatic arthritis, there is an urge to give high doses of steroid that actually aggravate many times psoriasis. So
Absolutely.
it works well with NSAIDs and methotrexate.
The second question is, if a female is on methotrexate and accidental pregnancy is detected, what should be done?
So as Malviya sir said, he always suggests they go for MTP actually. But if the patient is not ready, then we should actually convince her and a proper counseling should be given. Then high doses of folic acid or folinic acid should be given, like 15 milligrams BD or DDS. And we go for genetic counseling and we go for chorionic biopsy for the genetic diseases. If the patient is actually not willing for MTP, otherwise one should avoid that.
The last question is, what is special about the use of hydroxychloroquine in HIV positive patients?
HIV has got 2 components. It's like HIV associated arthritis or HIV diseases with, drug treatment, that always itself causes arthritis. So if patient is having HIV, then HCQ can be given, but then many times the retinitis is very common with HIV and ISTRA. So we should take care of that before starting HCQ. If there is already retinitis and maculopathy.
I will like to
Dr. Anuradha.
precautions in a childhood juvenile rheumatoid arthritis.
Sorry, childhood juvenile arthritis.
Juvenile rheumatoid arthritis. Any special instruction?
In juvenile rheumatoid arthritis, the treatment remains the same. We look for the disease, because juvenile rheumatoid arthritis, we have to be very particular in diagnosis, because underlying malignancy is a great mimicker in juvenile rheumatoid arthritis. So we start with the HCQ, we start with methotrexate. Methotrexate can be safely given in children, juvenile arthritis. Then sulfasalazine can be given, and steroid for a short term, we can give steroid also.
Dr. MP Singh, can I ask one question to Dr. Anuradha, please? Dr. Anuradha?
Yes, sir.
Yeah. How often do you monitor side effects of the methotrexate, SCQ, or leflunomide, first-line drugs?
Okay. So as I told you in the my slides, so initially when you start your DMARDs or biologicals, you should monitor with CBC, with SGPT, like hemoglobin should be more than 8, TLC should be more than 4,000, serum creatinine should be less than 1, and SGPT should be less than 80. So these 4-5 parameters we should look for every month. Once the disease is settled, then on follow-up, every 3 months we go for these monitoring. So for SCQ, eyes, right? So
I check up in SCQ therapy.
Yeah, so these are demands. For SCQ, if patient is elderly, patient is already having retinitis or maculopathy, then it's absolute contraindication. But if the patient is on HCQ, and one should go for yearly checkup in HCQ. Yeah. And if it is normal, then 5 hours, 5 yearly we can go for if it is absolutely normal. Yeah.
Very, very rarely I do come across patients of Still's disease. Where do I classify them according to?
Still's disease has got actually
I mean, they have
2 age groups.
And leukocytosis. That is confusing. That is confusing with polyarthritis septic arthritis. Yeah. And I'm very much afraid of giving the steroids. While steroid is the drug of choice in Still's.
Yeah.
Felty.
Yeah. So one thing is that we go for ferritin levels. So ferritin levels are very, very high in Still's disease. Still's disease has got 2 age groups. It is in the children, and if it is in the adult, it's adult onset. But ferritin, level of ferritin remains the marker, right? And then we have to decide whether it is disease activity or it is infection. So the best part is CRP doesn't help much. The ESR CRP ratio is important. If it is less than 2, it is inflammation. If it is more than 12, it is infection. Number 2, you go for procalcitonin level. It is high in infection while it is normal in flare, right? So these are few criteria. Then you look for rashes.
Hello.
So if rashes are there with high ferritin and joint chloride, it is chances that patient has got flare of Still's disease. If rashes are not there, fever is not there, and that we can think that it is infection. And then neutrophilia. Neutrophilia is very important. If you see the toxic nodule on PBF, that favors infection. So these are 4 points where we should look for.
Neutrophilia is also in Still's disease. Splenomegaly is there.
Yeah, but we have to see it, the toxic nodule, as I said, neutrophilia with shift towards that, and toxic nodule are there. Plus, we have to see all the factors, and procalcitonin is there. Because neutrophilia, leukocytosis is still there with the steroid therapy even. So if procal is positive, there is in history, I mean, a history of exposure to some infection, there is some document of blood culture or UTI or pneumonia, then these are a few indirect evidence where we can differentiate whether it is flare or infection. Yeah.
Thank you, Dr.
Yeah.
Thank you.
I would just like to say one thing. Somebody had asked about HIV and SCQ.
Yes,
The in vitro data has shown that SCQ suppresses the replication of HIV, going through the transcriptional processes. So that is why that has generated little hope, and people prefer prescribing SCQ in patients with HIV and arthritis. And the other thing was that in AOSD, it's all, as rightly Dr. Adna said, that there's a diagnosis of exclusion. So before making the diagnosis, anyway, we are excluding infection and malignancy. So one can be very confident in prescribing DMARDs in these patients because we are not using upfront biologics.
Right.
There's
Very
another
sad.
question in the chat box, and this one is for Dr. Uma Kumar, ma'am. The question is like this: in case of planned pregnancy, when should methotrexate be stopped, and can steroids be used instead of it?
Yeah, Dr. Adna has already answered that question, but I would again tell you that the patient who had conceived while being on methotrexate has to be given the option of termination, explaining like counseling, genetic counseling has to be done. Ideal is terminating the pregnancy, but many a time patients, they don't agree for it, can continue with the pregnancy under supervision. And steroids are equally bad during pregnancy. We have drugs which can be given during pregnancy to control rheumatoid arthritis, and the dictum which used to be like rheumatoid goes into remission during pregnancy no more exists true. So sulfasalazine, hydroxychloroquine can be safely given to these patients. If needed, low dose corticosteroids can be given, and if affordability is not an issue, then even anti-TNF agents can be given to these patients these days.
Thank you.
Dr. MP, can I ask a question, please?
Sure, sir. Go ahead.
First of all, congrats to all the speakers for such a nice presentation. Ma'am, I wanted to ask you, how do we differentiate methotrexate-induced lung disease from ILD because of rheumatoid arthritis?
Look, these days it is said it's a misconception to say that methotrexate causes ILD. And in fact, it's been seen that patients who were on methotrexate for a longer period of time had less prevalence of ILD than those who were not on methotrexate. So the problem comes that if the patient has interstitial lung disease and has been on methotrexate, can develop hypersensitivity pneumonitis. There would be worsening of already existing respiratory symptoms. At that point of time, it can create an issue because one would think that it is only worsening of pre-existing interstitial lung disease. In fact, that could be methotrexate induced in hypersensitivity pneumonitis, which can occur anytime ranging from 3 months to even after stopping methotrexate, it can occur during initial few months. That is the only concern. So even in patients who have interstitial lung disease in rheumatoid arthritis, it's safer to continue methotrexate under supervision. And to differentiate hypersensitivity pneumonitis, we all know there could be eosinophilia, and even when the BAL is done in these patients, there could be raised eosinophils in the BAL fluid. Radiologically also it can be decided to a certain extent.
Okay, but thank you.
Thank you. And before I invite Dr. KK Parikh sir to give the vote of thanks, I am happy to inform the House that we were hit a century on our debut. There were more than 100 participants during this online CME.
Very good.
Very good. I think we were more than 150, I think so.
115. Yeah. I
115.
wish to comment one thing. I must congratulate the organizers today, because it's not only the attendance. If you see up to the delivery of a talk by Aradhana, there were 90% persisted after joining with the talk. it clearly indicates the high standard of the talk which were given by all the three speakers. And I am very happy to see Uma and Aradhana. I never knew Aradhana had been my student during MBBS at SNMC. So it's nice to see you, Aradhana, today. And Uma, with the new face and all that, and you have matured to a good rheumatologist and heading the All India Institute. Congratulations. And in the last, I must congratulate Dr. K.K. Parekh, Dr. M.P. Singh for organizing such an excellent and a good online on debut over with a century mark over it. Congratulations once again, Dr. Parekh.
Thank you, sir. Thank you.
Sir, next time cases रख लेना, interesting cases.
So,
Clinical cases.
friends, it had been a wonderful meeting, and I must compliment and congratulate our speakers masterly talk, their talk, and because of them we could collect so many delegates. More than 100 delegates were there. This is because of the presence of our master teachers today, and I also congratulate our guest of honor, Dr. Girish Mathur, President API, Dr. M.M. Singh, sir, for sparing your valuable time. Guest of honor, Dr. H.S. Pathak and Dr. Subhash Chandra, our past president, our president-elect, our Dr. Chawla moderated, so nicely moderated this session, and so many delegates attending this meeting, such a common topic. So thank you so much, and I hope that we will have many more such CME programs every month. And I must inform all of you that this CME has been recorded and will be sent to you on almost all groups, so that those who have not attended can get the benefit of getting knowledge and dissemination of this approach to a poly. So thank you very much for attending this CME, and we had a most important, very good interaction. The most what is on CME is the interaction between the delegate and the speakers. That was wonderful. So thank you very much, all the speakers, Dr. Uma, Dr. Aradhana, and Dr. Satija, for giving an excellent talk, deliberations, and Dr. M.M. Singh, sir. Thank you very much for sparing your valuable time. So
Thank
good
you,
night,
sir.
everybody.
Good night, sir. Good night. Good
Thank
night,
you.
everyone. Yes, sir.
Good night, Jay.
Good night, sir.
Good night. Good night.
Good night.